Good afternoon, and welcome to today's webinar titled Psychiatric Advanced Directives, Supporting Voice and Choice in Mental Health Crisis Settings, sponsored by SAMHSA and developed under contract by the National Alliance on Mental Illness, also known as NAMI. My name is Kelly Maston from the National Association of State Mental Health Program Directors, and I would like to thank you all for joining us today. Before we introduce today's presenter, I would like to go over a few housekeeping items. Today's webinar is being recorded. The recording, along with the PowerPoint presentation slides, will be available on NAMI's website at www.nami.org and the NASHPD website at www.nasmhpd.org within a week. For participants only, audio is being streamed to your computer speakers with no need to connect by phone unless necessary, in which case the phone number is listed in the notes section on your screen. If you are having any technical difficulties during this webinar, please type your comment in the Q&A pod on the right side of your screen, and someone will be able to assist you. Please also type your questions for the presenter in the Q&A pod, and at the end of the presentation, we will ask as many as we can. The PowerPoint slides are available at the top of your screen where it says PowerPoint Presentation. Please click on Upload File to download the slides. At the end of the webinar, we ask that you take a few moments to complete a short evaluation for us. Please also know that we do not offer CEU credits for our webinars, but will send you a letter of attendance upon request. My email address will be available at the top of the screen during the evaluation. I would like to thank SAMHSA for allowing us to share this information with you today, and again, thank you for joining us. I will now turn it over to Jessica Hart from NAMI, who will introduce today's presenter. Jessica?
Thank you, Kelly. Today's presenter is B.B. Smith, who is the Director and Coordinator of the North Carolina Evidence-Based Practices Center. She's also Project Coordinator for the Crisis Navigation Project, a collaboration between the Southern Regional Area Health Education Center, Duke University Medical Center, and NAMI North Carolina to promote the use of Psychiatric Advanced Directives, or PADs. Before her current position, B.B. worked for 21 years at the University of North Carolina at Chapel Hill in the Department of Psychiatry and the School of Social Work. She has taught mental health professionals from multiple disciplines in clinical and academic settings. Her clinical practice included psychotherapy, family therapy, clinical case management, and team-based models of care. Using a life course perspective, she is focused on providing evidence-based treatment and services to people who live with schizophrenia and other severe mental illnesses. B.B. helped develop OASIS, the first early psychosis program in North Carolina at UNC in 2005, and was the founder of the UNC Center for Excellence in Community Mental Health in 2008. She also led a pilot of the critical time intervention from 2012 to 2015. CTI was adopted for statewide expansion in 2014. She's a trainer in family psychoeducation and critical time intervention. She was the National Association of Social Workers North Carolina Social Worker of the Year in 2012 and won the Bryan Public Service Award from the Carolina Center for Public Service in 2015. We are very lucky to have B.B. talk with us today. Now I'd like to invite B.B. to begin her presentation, Psychiatric Advanced Directives, Supporting Voice and Choice in Mental Health Crisis Settings. Thank you, B.B.
Hi. Hi, thanks. It's good to be here today, and I do have to tell you the sad news that I seem to have been bumped out of the Adobe Connect classroom. So I may need some help getting back in. While we're figuring that out, I got sort of put to a page that says, that had to ask for a password. So if you can give me any guidance on getting back in the room, I can chat
Absolutely,
a little.
Absolutely, BB. If you want to select the guest option and type your first and last name in, I can promote you back up to presenter.
Okay, hang on. Let's see if I can get back to it. I think, let's see, I may need another page link to connect to, so let me see if I can get back to the original login that I had. Technology is great when it works. and it does often work quite well, and I have faith that it's going to get back to it. All right. I can see slides now, and people can hear me, so that's good. Yeah, so thank you for the introduction. I'm very glad to be here today. One of the things that I will say as we get started, just to give you a little bit of my background, I was a practicing clinician for 21 years, and I've had a few years now where I've been doing some teaching and training and project coordination, but it's really been quite an honor to me to be able to work with people who live with severe mental illness. My clinical specialty was in working with people with psychotic disorders, and so I will try to infuse today's webinar with a little bit of some of the personal experiences that I've had with folks in developing psychiatric advance directives. This is our standard disclaimer slide from SAMHSA, giving the background on the funding and support for this webinar. I'm also going to say that I am sort of giving a talk today, giving the webinar, but I am working with a team of people. So the materials, some of the materials that I will be presenting on today are developed with some of my colleagues at Duke, most notably Marvin Schwartz and his research team. They've been doing research on psychiatric advance directives and promoting their use probably going on 20 years now. So while I'm the person you're hearing talk today and giving this presentation, there's lots of people who've been involved in these efforts and what's currently going on with our project, with the Crisis Navigation Project, which is really kind of an implementation and dissemination project that's rooted in research that's been done previously. So there is a big team behind me. So here's what we are planning to do today. We're going to define psychiatric advance directives, review the evidence base for their use, and describe state strategies, particularly here in North Carolina, to disseminate advanced care planning. And we're mostly going to focus on the work that we've been doing in North Carolina, knowing that there are things going on in other states. And if there's anyone here from other states, and when we get to the questions, or if you want to put comments about what's happening in your state around this topic, we'd be very much glad to hear about it. And then I'll also talk about some of the resource materials that are available to support broader use of psychiatric advance directives. So I want to start with this slide because to me it really represents one of the major principles around the use of psychiatric advance directives and advanced care planning in general, and that is that it's really at its core a tool for collaboration. That's me on the right in the selfie with two of my collaborators in Charlotte. In the middle, that's Judy Reiner. She is active with NAMI Charlotte, and she is one of those boots on the ground folks. She also works with coordinating the CIT trainings in Mecklenburg County, and she's been helping lead the project in Mecklenburg County. So she's been very big support to me since I live in another county in North Carolina. And then on the left, that's Shireen Carico. And Shireen is a person with lived experience, and she has also been a key partner in our initiative. She is the executive director of an organization called Promise Resource Network, also in Charlotte, North Carolina. But I thought that this photo just kind of represents sort of three different perspectives: a perspective of lived experience, the perspective of a family member, and then the perspective of a clinician. So with the three of us and sort of thinking about if we can use these tools to kind of promote collaboration between all of us, that may help, particularly the person who lives with mental illness and mental health challenges. So I'm going to just throw this question out to people, and this is it's hard to have discussion in a webinar like this, so it's something just for you to think about. And it's to think about if you've ever been in the hospital or a crisis setting before, and this doesn't have to be related to mental health, but any kind of medical crisis. And then thinking about, was your voice heard during that time period? And just, kind of think for yourself what situations you might have been in, and whether you had kind of a good experience of your voice being heard or kind of a bad experience where you thought your voice was not heard And I'll just throw out something from my own experience. A few years ago, I had an elderly cousin. She might have been in her late 80s at that time. She actually was functioning very, very well, but her husband was having some struggles with dementia, and he ended up being hospitalized at a psychiatric hospital. But no one told her that he was actually being hospitalized at a psychiatric hospital, so she didn't understand what was happening in his situation. And she went to visit him. The hospital was a couple of hours away from where she lived, and she went to visit him. When she got there, they told her that it wasn't visiting hours. So when I think about what happened with my cousin is that she just, no one sort of explained to her what was going on, and it was a very confusing process for her. And I think even when I talked to her about sort of what was happening, I'm not sure she fully understood what the difference was between a psychiatric hospital and between a regular hospital, because her husband had initially just gone to the emergency room. So you might also think about some things from your life that have perhaps been challenging when you were in kind of a medical emergency. Just to think about that. So a psychiatric advance directive then, and why that's relevant, is that it's something that is a legal tool that can support your voice when you're in mental health crisis. And the idea is that you create it before a crisis occurs when you're in a good frame of mind. So that's kind of the basic definition that we'll be talking about for a PAD. And I use that shorthand PAD. I know that for some people that I've talked with about this, the language that we use, some people have some issues with the language, but that is sort of a shorthand that the psychiatrist that I've worked with has used for a number of years. So if that's, it becomes kind of an easy way to describe it. So that's the basic definition. And this is kind of why they are important. They can support a person's autonomy and empowerment in mental health treatment. They may reduce involuntary treatment. And that's actually a big thing. What we have found in Mecklenburg County, and one of the reasons we've been doing some work there or had sort of some people interested in working with us in our training efforts, is that they've had a significant increase in the number of involuntary commitments in their county. And the reasons for that are, probably multiple and complex. But on the research studies that my colleagues at Duke have done, it's shown that psychiatric advance directives might help reduce the need for involuntary treatment. They might improve the continuity of care between inpatient and outpatient settings. And they can allow make it clear, like who's the person to talk to in a crisis situation if someone's having a hard time speaking for themselves, and just if somebody needs kind of an alternate decision maker, then that can be included in the PAD as well. But it might also be helpful to stop and talk about some people I've worked with who have created their own psychiatric advance directives. One situation a couple of years ago, as we were getting our project started, I worked with a young man who his family had been encouraging him to develop an advance directive for a number of months. He was somebody who was in his 20s. He had multiple psychiatric hospitalizations all around kind of the start of the sort of initial development of a serious mental illness. And he and his family really wanted to avoid any involuntary hospitalizations in the future. So I was able to sit down with him and sort of talk through developing what he would want in his treatment. And he was able to have conversations with his family members about who he would want to be involved in his care if he was not well and couldn't speak for himself. And then the whole family was kind of appreciative of that process. And I think for them it was kind of like we went through this really scary time where it wasn't, everybody was kind of in crisis when our family member had a psychotic episode. And now we've kind of got a plan for what to do in the future. So that was kind of like almost a family intervention that was helpful. I also thought about some people that I've known through the years. There was one woman that I've known for a long time. We're actually on the board of a clubhouse program together, and she has had a psychiatric advance directive for a number of years. And she originally developed hers in the context of outpatient psychotherapy, and has found it to be a very important tool for her in specifying that if she has a manic episode, that her brother can be the person to come in and help make decisions about her care. So it's kind of, it gives her some peace of mind to know that she's got that in place. And then just recently, I had another person that I know from a clubhouse community reach out to me because he wanted to create a psychiatric advance directive. There had been some changes in his life. His mother had died recently, and his longtime psychiatrist was moving to another part of the state. So he had thought about creating an advance directive for a long time, but had never sat down and done it. And he knew very clearly the kinds of things that he wanted to make sure would happen in his treatment. He had not been hospitalized for probably 20 years, but he had been treated with clozapine, which was a medication that had been very effective for him. And he knew that if something happened to him, that he wanted to stay on that medication, even if he had medical complications that were related to it. So that's the kind of thing that where a person who's given a lot of thought to what's important about their treatment could put that kind of in a legal document, and it kind of gave him some peace of mind. He also knew that he wanted to designate a family member to be his healthcare agent, but he knew he also had to have those conversations with the person beforehand. But I was able to sort of talk with him about it, and he sort of thought through some things and had a few follow-up things to do. But it also felt very good to him to get that process started. So those are just some sort of real-life scenarios. So this I want to talk again, so what might a psychiatric advance directive look like in practice? So I will read this slide that kind of gives a case scenario of how a psychiatric advance directive might work. So Ms. Jones, she is picked up by the police after she is found wandering and mute. She is wearing sandals and a t-shirt, and the weather is very cold. So the police transferred her to a crisis facility. And in the crisis facility's electronic health record, there's an indication that Ms. Jones has a psychiatric advance directive. So the advance instruction there gives information about her history and what her medication preferences are. She also has a healthcare power of attorney, and her sister is listed as her healthcare agent. So once the psychiatrist sort of sees that, and he kind of examines Ms. Jones and finds that she's currently lacking capacity based on her inability to attend to his questions, and that she's not able to really talk to him about what's going on, and he kind of makes an assessment that she doesn't seem to be relating to reality well, he kind of decides with that clinical judgment that she is lacking capacity in that moment. And that's kind of the key time that the psychiatric advance directive goes into effect. So he documents that she's currently incapacitated and puts that in her medical record. But because she had made some decisions in advance about what she would want to happen in her treatment, he knows that he can call her sister. And the sister gives him further information about Ms. Jones and what she would want in terms of her treatment. And then the sister comes to the crisis facility, and she's able to sign paperwork allowing Ms. Jones to be admitted voluntarily to the hospital. And then Ms. Jones, who is relieved by the presence of her sister, whom she trusts to speak for her, and she calmly agrees to the hospitalization. Now, this might sound like it's a scenario that doesn't happen that much, but this is the kind of thing that a psychiatric advance directive could do to kind of help along with admission to a hospital to avoid involuntary commitment. If Ms. Jones had shown up and she didn't have a document like this in place and hadn't made these decisions in advance about her treatment, the attending psychiatrist would have probably had to move forward with an involuntary hospitalization because she wouldn't be in the state of mind where she could consent to treatment. And if anyone listening has been is either works in a clinical setting or has had an experience of hospitalization themselves, you know that you have to sign a lot of forms consenting to treatment and those kinds of things. So that might be sort of like an ideal case scenario. It's actually based a little bit on someone that I worked with who, in her history of schizophrenia, when she had a psychosis come upon her, she tended to leave home, and she would go to another city. She would end up being on the streets, and sometimes would be found catatonic, and then she would be hospitalized, but she'd be hospitalized at a place that didn't have any information about her, and it took some time for her mind to clear so that then she could give some good information to the treatment team, and they could help her in a way that she actually did find helpful. And she did have a family and a home, so she'd end up being sort of seen as someone who was homeless, but she did in fact have people who cared about her. So just to go back a little bit and sort of give you some history on where psychiatric advance directives came from, we can look back to the Patient Self-Determination Act of 1990. That was a federal law, and it said that patients should be given information about their rights in medical settings, and that people should be offered information on advanced care planning. That advanced care planning originally started around end-of-life issues, talking about a person's choices around treatment to sustain life in life-threatening situations. But these same kind of principles apply to planning for a mental health crisis. Now, there are some differences. One of the things that's pretty clear is that for somebody who is looking at end-of-life issues, they're thinking about a state in the future that they've never experienced before. And then the people who are developing psychiatric advance directives usually are basing what they put in that document on experiences that they've had in the past with psychiatric hospitalization. So they are a little bit different, and there are questions certainly about, you know, sort of the parallel nature of those. You know, my hope is that when we sort of move further along with integrated care and sort of looking at the whole person, that there might be sort of a broader advanced care planning documents and things that we can do that sort of pull together the mental health aspects of it, and then maybe even the dementia aspects of it as well for people who are experiencing those kinds of challenges. So this Patient Self-Determination Act, it was based in a, Congress was inspired to act on that from a Supreme Court decision. It was called Cruzan versus the state of Missouri. And that was a situation where a woman who was in a vegetative state her family wanted to remove life support, and the state of Missouri said that they couldn't do that because the woman wasn't making that decision, and she didn't have that capacity to make that decision. But the idea was kind of rooted in that people should have the right to make decisions about their medical treatment, but if they lack that capacity in the moment, that if they have a document in writing that they prepared in advance, that is something that should still hold for the person's preferences about treatment. So that's kind of the legal origins of psychiatric advance directives. So that law then spurred regulations, and that hospitals are required to follow. And those are kind of, for any clinicians that are listening in or any administrators at hospitals that might be listening in today, there are rules then that say there are standards that we should be respecting patients' rights in the hospital setting. And that part of that is that people should have the right to make decisions regarding their care and to formulate advance directives. And that would be on the medical side or on the psychiatric side. And then patients also have a right to appoint someone as their representative and to have their personal physicians notified promptly if they're in the hospital. So those are kinds of regulations that govern psychiatric hospitals and are also relevant to advance directives. So since the 1990s, there really has been kind of increasing interest in using psychiatric advance directives. And as you know, if you live in the U.S., each state is different. So I do want to make sure that we have that caveat in mind that states are going to have different laws regarding psychiatric advance directives. But here's just a history of kind of how the states have kind of bought into this idea that they should have laws on the books, looking at advanced care planning and mental health. You can see that, we had a few states in the early 1990s, and more in the later 90s. The early 2000s saw some good growth. And then, it's still, we don't have every state doesn't have the laws on the books, but a good number of them do. Nevada, one of the latest ones to join in 2017. And even if a state doesn't have laws that are specific to psychiatric advance directives or mental health advance directives, there are laws around advanced care planning in general and being able to appoint healthcare agents. And those would also be relevant for people with mental health issues. So there's another sort of idea too, and let's see, my colleagues at Duke have done a number of different research studies on psychiatric advance directives, and one that they did was in 2004. They did a survey of 1,011 psychiatric outpatients, and they asked them, have you completed a mental health advance instruction or appointed a healthcare agent for future mental health treatment? And the people they surveyed, only 4 to 13% said yes. So there weren't very many people who had psychiatric advance directives. However, they followed up that question with a second one, and that second question was, would you want to complete a psychiatric advance directive if someone showed you how and helped you to do it? And then the interest went up to about 66 to 77% of the people said yes, they would like to have one if they knew more about it and knew how to get one done and had someone to help them with it. And when I think of this slide and I think about this study, I think about this sort of idea that we created a tool for people who live with serious mental illness, but we made it very complicated and we made it sort of hard for them to access. So that's one of the things that we're trying to do with our training initiatives, is to kind of make it more accessible and make it so that people who might be interested in this have it as something that they can develop. And then that gets us to this sort of larger question as well of this idea of how do we get research into practice. So my colleagues at Duke have been doing research studies on psychiatric advance directives and many other things for a number of years, and they've got some good information about, they know that people want them. They know that they can help avoid some things like involuntary commitments. They know that they can improve communication amongst people in mental health crisis settings. And they also know, sort of how many states have the laws and all of that. So then, but how do we get them sort of out there and so that people can use them? And it's really something that's kind of multiple levels of education and information that need to get out there so that people can use them. So I'm going to talk a little bit about some of the specifics in North Carolina, since that's the state that I know the best, and that's the place where I've been working on this initiative. And so written into our statutes that are specifically addressing mental health, our mental health statutes in North Carolina in the law, it says that an advance instruction allows you to consent to treatment in advance and to state your preferences for treatment, including medications and the facility you prefer if you need to be hospitalized. Now, there are some caveats to those kinds of, stating the preference. I'll talk about those in a little bit. And then the healthcare power of attorney allows you to select a person you trust to represent you if you cannot speak for yourself. That person is called a healthcare agent and should represent your preferences and serve as your advocate. So in North Carolina, people can have one or both of those legal tools, and of course, just remembering that the laws vary by state. We often recommend that people have both an advance instruction and a healthcare power of attorney. But there are sort of different ways, and depending on a person's preferences, ways that they can do that. So the other thing about sort of where these exist in our statutes in North Carolina, the healthcare power of attorney applies very broadly to care in any kind of medical setting. But the advanced instruction for mental health treatment, which is the way it's described in the law, is very specific to mental health treatment. So who can make an advanced instruction? It's sort of any adult of sound mind can make one. And I have that sort of sound mind in parentheses because that's kind of like a ballpark layperson's determination of sound mind. The law in North Carolina states that once the person makes their advanced instruction, that it has to be signed in the presence of 2 witnesses. Those witnesses can't be a relative, and they can't be a person's treatment provider or be employed by the healthcare facility. The reason there are those restrictions to the witnessing is that we don't want to have any kind of sense that there's coercion around making a person create one. And this is kind of an important thing for family members who might be listening in, because I've talked with family members before who've been like, I really, really want my son to create his advanced instruction, and this is what I want him to have in it. So the thing that needs to be really emphasized is that this needs to come from the person and sort of focus on what they want in their treatment. And sometimes that aligns well with what a family member wants, but sometimes there might be a little bit of differences in that. So the documents also must be notarized. That is something that is a little bit of a barrier to people completing them, just some complications of how do you get that done. And then once the document is prepared, it needs to be presented or communicated to doctors and other mental health treatment providers, to emergency place a person might show up in a psychiatric crisis. So capacity, that is actually a legal term that describes a person's ability to make rational decisions based upon relevant facts and considerations. So this is something that is usually time limited. It's the kind of thing that is a judgment that either a physician or an eligible psychologist makes kind of in the moment. So it's kind of a bedside decision of whether this person has capacity to make decisions for themselves now, or if it doesn't have capacity. And there's many reasons why a person might not have capacity at a given moment in a medical or psychiatric emergency. One is that they might be unconscious. That's kind of a very clear time when a person lacks capacity to make decisions. They could be intoxicated. That might be another time when they lack capacity. They could be experiencing just extreme confusion. They could be delirious. They could be experiencing psychosis or mania. So those are the kinds of things that might lead a physician to say this person lacks capacity at this moment in time. But that's generally something that is time limited, and it's a clinical judgment. And this is important because that's when the advanced directive would go into effect, is when a physician says the person lacks capacity. It's different from competence. Competence is something that is a legal determination that might be based on a more long-standing inability to make rational decisions or an ability to have sort of a cognitive capacity to make decisions for themselves. So competence is something that is legally adjudicated by a judge. It might be based on some clinical information or some information from a psychiatrist or a physician, but it is not the same as capacity. Capacity, at least in this is sort of a time-limited kind of state. And again, we kind of encourage people to think about it as kind of a layperson's kind of version of that, and kind of understanding. Again, yeah. So treatment providers then. So the mechanism in North Carolina for the Psychiatric Advance Directive to go into effect is that a physician would determine the person is currently lacking capacity. So they would have to document that in the record. And I'd say Ms. Jones currently lacks capacity, and I will now refer to her advanced instruction for information about her preferences for treatment. So there are exceptions, and this is something that sometimes people with lived experience of mental illness feel like PADs don't have enough legal power behind them, is that there are exceptions, and there are a lot of the power still remains with treating clinicians. So the exceptions in North Carolina are that if the person asks for something that is not standard care, or if the person, and that might be saying that in their advanced instruction that they want to be treated with ginkgo biloba if they are not mentally well. That might not be considered standard care. Or say they ask for something that is not available or not feasible. That might be like asking to be hospitalized in a private hospital in another state. That might not be feasible. We also run into this, and I'm sure other states do as well, is that sometimes hospitals don't have beds available. But the person might say, I'd prefer to be hospitalized at Central Hospital, and if that hospital doesn't have beds, then they may not, the treating physician might not be able to respect that choice. There are also exceptions for emergencies or if there are safety issues present and if the person is under an involuntary commitment order. But even if a person is going through that involuntary commitment process and is under a custody order or going through that process, there might still be very helpful information in the Psychiatric Advance Directive that would help the people who are providing treatment to kind of know, oh, these are the things that have worked for this person in the past, or these are some of the ways that we can respect their preferences. So they should still be kind of paid attention to in that. So the details behind the healthcare power of attorney, that's sort of a separate piece, but an important one that allows you to appoint someone to make treatment decisions for you when you are incapable or incompetent. So if the person has a healthcare power of attorney, that healthcare agent, that's the person who is designated by that legal document, the healthcare agent can then make decisions for the person, but they should make the decisions based on what the person wants, not what they think the person needs. So that's an important distinction there. People can also have more than one healthcare agent designated. So it might be that this is the first person to call, and then if that person's not available, call this person, and then this person. So when I think to the young man that I worked with, I think his father was the first person on his, to be called for a healthcare agent, and then his mother, and then his brother, kind of in that order. And, you know, he gave a little thought to how he would want that to play out. So this can be combined with the advanced instruction, but it doesn't have to be. They can be two. The person can have one or other of those. And I've already mentioned this, but the Psychiatric Advance Directive goes into effect when the person lacks decision-making capacity, and that's based on that examination and documenting that. So that's just the mechanism of when it goes into effect. So the process can be kind of complicated, as you might have heard. I see over in the comments there that we've got someone from California saying you have those in California too, and I'm glad to hear that. If you weren't on that chart earlier, then send me an email and we'll make sure we get you on that. So policy and practice, there's sort of things happening on multiple levels, and I do want to start back at kind of the national level and give a little bit of a shout out of appreciation to SAMHSA for having an increased focus on psychiatric advance directives. That picture up there at the top of this slide, that's me on the right, and that's my boss, Lisa Hewitt-Robinson, here at Southern Regional AHEC. But a little more than a year ago, we were invited to attend an expert panel on psychiatric advance directives that Dr. Anita Everett had called at SAMHSA. Marvin Schwartz was our connection, and he, of course, was there along with his colleague, Jeff Swanson, and then other people from around the state to kind of talk about what could we do to kind of support the use of psychiatric advance directives. There has been a document that has come out of that meeting, which is a practical guide to psychiatric advance directives. You can see the link there to that document. that again is something that I helped develop and is kind of based on some of the things that we were doing in North Carolina. So hopefully it will be relevant to other states as well. But it really is kind of to get people sort of thinking more about some of the practical implementation strategies. Here on the state level in North Carolina, we've also had some things happening with our state legislature. And last year in our state legislative session, the General Assembly passed some revisions to our involuntary commitment statutes in North Carolina. And they were trying to address some of the things, one, to kind of modernize the laws so that people could use technology more efficiently in some of the processes around an involuntary commitment. They were also looking to reduce the use of restraints, and they were increasing the number of people who could do first-level commitment exams, and they included a piece that was specific to promoting the use of psychiatric advance directives. So we were pleased that that was written into the law, but that is another way that policy can help support implementation of practices that are worthwhile. And then kind of on the local level, I'll use Mecklenburg County as an example for that. And our colleagues in Mecklenburg County have taken some of the training that we offered, and they're working with their mental health action plan and trying to get local leaders more on board with doing more with offering training and offering settings and actually working with health systems to do more along the response to psychiatric advance directives. So that's written into a mental health action plan in that county. So it just kind of gives you the different levels of policy that can be involved in getting practices out there to the people who might benefit from them. Just a little bit of further detail about Mecklenburg County, kind of using that as a case example. A couple of years ago, they had a judge who was concerned about the rise in involuntary commitments in that county. And he had formed a variety of committees. There was one that was actually an IDC, a post-discharge, post-IDC subcommittee. And some of the people in that committee were interested in psychiatric advance directives and had actually reached out to Marvin Schwartz at Duke about, can we get some help with trying to implement these in our community. That committee also developed into a PAD steering committee where they were developing a community-wide strategic plan for an implementation of psychiatric advance directives. We were able to provide some training to people who were interested in becoming facilitators. I'll talk a little bit more about that in just a little bit. But they also started meeting regularly to sort of talk about how can we make this work better in our community. The Mental Health Task Force then kind of added that to the mental health, the countywide mental health action plan. And then a local agency, Promise Resource Network, started offering workshops on PAD creation every 6 weeks. And that was to anyone who wanted to come in could get information and help completing a psychiatric advance directive, and they would have notaries and witnesses available to kind of help someone go from start to finish if they wanted to do that. So that's just sort of highlighting their efforts. In terms of communication, this is our project website, and I might just back up and say the Crisis Navigation Project is an initiative that is funded by a local foundation in North Carolina. It's funded by the Duke Endowment, but it really is kind of an education and dissemination project to see that if we can train more people both in what psychiatric advance directives are, and if we can train people to help as facilitators to help people create theirs, that perhaps there would just be more out there in practice. So this is the website for our project. And it kind of leads to, we do have some resources up on the a lot of our local partners can just get resources and forms and different things on our resource page. They're there. I skipped one slide there. And part of our educational initiative has included a blended learning opportunity for people who are interested in learning how to facilitate psychiatric advance directives. We're doing this training, so we have a two-part course. The blended learning, it's sort of a 3-hour course that the first part is online, and we enroll people in that course and they can take it on their own time. It's available to people in 4 different counties in North Carolina. And then we follow that up with a skills workshop. In the online course, people get some basic information about psychiatric advance directives. There's a short documentary video by a filmmaker named Elaine Rustin. And they watch a mock facilitation, and there are articles and things that they can read if they want to go further into the topic. And then we follow that up with, we have a skills workshop. And this is a photograph of some of the people who participated in our skills workshop in Charlotte in 2017. One of the main things that we do in the workshop, when we get to the skills workshop, is that we give people an opportunity to do mock facilitation. So they split into pairs and interview each other and get some familiarity with the legal forms, which I think is one of the challenges. The legal forms are written in legalese, as legal forms often are. The people that we have offered the training to, it's kind of a broad group. We initially were going to recruit NAMI volunteers to become trained as PAD facilitators. But we kind of realized early on that we needed to be a little bit more broad than that. And so we have offered training to clinicians, mental health clinicians, to peer support specialists, to community volunteers, and to NAMI volunteers. So we have trained a number, I think close to 50 people in Mecklenburg County, and then people in other counties as well in North Carolina. And their job, once they get to be trained as a facilitator, we hope that they connect with people who are interested in creating a PAD. So that's the training that we've done. As we got into our project, and the Crisis Navigation Project was really kind of started by Marvin Schwartz and colleagues with the idea that we needed to do something to increase the number of PADs out there in the community to hopefully get some, get more people using them to hopefully sort of improve what was happening in mental health crisis settings. We did realize early on that there was a lot of complexity to the project. We definitely wanted to keep it the person with the PAD in the center of our attention, but we knew that there were all these different systems that the person would intersect with. So we've tried to kind of, and some really key ones are the health systems, crisis response, the legal and criminal justice systems, and the family and social networks. But there's all an outpatient provider. So there were sort of all these different people that we needed to provide some kind of overview training to, and to try to create some change in the broader systems that would intersect with people. NAMI North Carolina has been a key partner in our initiative, and one of the things that they did was to create a series of educational videos on PADs. I'm not going to test the technology too much to see if we can play this video, but this is one that is just a 1-minute, very brief overview. The woman in this video, her name is Barjan Lee, and she is a peer support specialist, and she talks for about a minute in this video just about the importance of psychiatric advance directives. So it's a really good, here's a very brief introduction to what psychiatric advance directives are and kind of their value for people with lived experience of mental illness. NAMI North Carolina has created a whole series of these educational videos. They've got a 20-minute one that goes into more detail. Now, of course, these are targeted to North Carolina-specific laws, but they might be a good model for other NAMI chapters in the country to develop. There's a longer one that's 20 minutes. There's one that sort of has the family perspective on psychiatric advance directives, And then there's one that explains the difference between the use of a psychiatric advance directive and guardianship. Guardianship is an intervention that is much more restrictive because that takes away a person's rights on a more permanent level. And we've also, in addition to seeing an increase in involuntary commitments in North Carolina, we've seen an increase in guardianship in North Carolina. So for the people who are more concerned or are concerned about the rights of people living with mental illness, the psychiatric advance directives can be an alternative to guardianship. That's also a very important thing for transition age youth, for young people who might be moving from being an adolescent who has been dealing with mental health issues and moving into adulthood. It might be a way for parents and adolescents to come together and kind of decide, here's some things that we want to do that will still give family members, parents some involvement in treatment, but not take the autonomy away from the young person, but allow them to keep the autonomy, but to make that sort of clear connection that the family can stay engaged in treatment. I know, I'll just say something from my personal experience. I have a son with congenital heart disease, and he's 19. When he turned 18 and we were at his pediatrician, you know, all of a sudden I didn't have access, total access to all of his treatment unless he gave me permission for that. And he didn't have a problem with me continuing to have information about his heart problems. So he, you know, signed so that I could have that access to his information. And that would be sort of a similar thing. But you know, he and I talked about it, and that's a little different because it's issues around his cardiology treatment, not his psychiatric treatment. But those are the kinds of things that families might have some benefit in sort of knowing about these tools if they have young adults in the family or people who are teenagers and are about to turn 18 and kind of figuring that out. If you want to find these educational videos from NAMI North Carolina, you could just type into Google NAMI North Carolina Psychiatric Advance Directives, and that should take you to the NAMI North Carolina video. All right. This is also, so there's also this question of, okay, so if once a psychiatric advance directive is completed, what do you do with it? So they're generally a multiple page document. And in North Carolina, a few years ago, our Secretary of State created a secure online repository for psychiatric advance directives. Now, this is something that people can choose if they want to upload their document to this site. They can do that. It's not connected to any health record, but it would be the kind of thing that if a person was maybe traveling, not at home, didn't have their documents with them, they could access their documents through this online repository. If people, there is a fee though, people have to pay $10 to have their documents stored there. But if they store their documents at this online repository, they get a card back with a logon and a password for how to, and that lets them access their documents from anywhere that they can get to the internet. Now, an online repository like this is a good tool, but it's not quite as good as our online medical records. So the electronic health record, if you have one yourself, you might look at it sometime to see what it has about advanced care planning. I know, and there are two large health systems where I have health records. One is UNC Healthcare, one is Duke, both in North Carolina. And if I pull up my own medical record, there is a section in them. They use a electronic health record called EPIC, which is used by many large health systems. They do have if I pull up my own electronic health record, I can find a tab that says advanced care planning on it. And it has resource information, and it has a way for me to upload my own documents. It does not, however, provide information on psychiatric or mental health advance directives. So I'm hoping that one day our healthcare systems will bring psychiatric advance directives into what they're already doing for advanced care planning on end-of-life care. That's the kind of change that we could use organizations like NAMI and the stamps that I'd be pulling for as well. So I know that I see some of the questions over there in the chat box, and I think we can make sure to go address those when I get to the end of the slide. But one was asking about whether Illinois has the same laws. Marvin Swartz, my colleague at Duke, he is the director of this National Resource Center on Psychiatric Advanced Directives, and there is information on every state's laws here at the National Resource Center on Psychiatric Advanced Directives. There's also just a whole lot of educational material on this website, kind of reflecting decades of work on trying to promote the use of psychiatric advanced directives. But if you're listening in from another state and you want to find out what the laws are in your state, this is a great resource for you. So I would encourage you to check out the NRC PAD, the National Resource Center on Psychiatric Advanced Directives. There's also a number of different kind of videos, and there's information on the research if you're someone who wants that academic information as well. And some of what we're doing with the Crisis Navigation Project is kind of making information accessible to more people. And some of the feedback that we've gotten is that we need to go even further with making our educational materials very accessible to people, kind of the different levels of literacy. So we're going to be working on that as we go forward. So one of the other things that we've done is as we try to get the word out about psychiatric advanced directives, we were very pleased to be able to work with a reporter a journalist from the New York Times who wanted to write about psychiatric advanced directives. And she was very clear in her focus that she wanted to connect with people who actually had psychiatric advanced directives and wanted to know what it meant to them to have them. So we worked with her probably for more than a year, doing a lot of the kind of background for that, and connected her with people, some people in the Charlotte area, and then she found some people in other states as well who talked about their experiences with psychiatric advanced directives. So that article, I've got the links there in the slides. The first one, it actually ran on the front page of the New York Times in early December of this year. And then she followed it up with a second article that was talking about her experience in working on the article. So those, we were very pleased to see those articles. And if you see the photo on the left, it's a young woman. I do believe she talks about that experience of being a young person sort of transitioning to adulthood. I'm seeing that I've got a little bit of a Adobe. I kind of went out of the meeting and now I think I'm getting back in. I'm still talking. You can still see me. Okay, good. Or hear me. That's good. So you can read those articles. I really did appreciate how much she focused on the people who have psychiatric advanced directives and their experiences with those. Then I'm going to shift a little bit to our practical strategies. And I will give a little bit of a caveat because over the past few years, I've talked to many people about psychiatric advanced directives. And there are some people who live with mental illness who have told me that they do not want to have one. So I think it's always important, like this is something to offer to people and to say this might be a tool that you might want to consider. Sometimes there might be a person who sort of says, I always want to make my own decisions. I never want to give away that power to either a document or to another person. So that person might not want to have a psychiatric advanced directive. I've also talked to people who have had one and then, or they've had a family member who had one and it wasn't respected when they came into a crisis setting. So that's another piece where we sort of still need to work on the learning. And it's not just the people who might want to create a psychiatric advanced directive who need to learn about them, but systems also need to learn about how to respond to psychiatric advanced directives and how to support the person's right. And there are some principles like shared decision making that go quite along with this. So one of the practical things, and I get back to sort of the practical strategies that we've offered in our crisis navigation project, and with our partners on the ground in Charlotte, is to offer these workshops. And this flyer was developed by staff at Promise Resource Network. They're a peer-run facility, and they really put the focus on learning about your legal rights. And they started offering these CAD workshops where people who were interested in them could come to the workshop. They could learn about them, but since we had all these trained facilitators, we also had trained facilitators come to the workshop to be present. And if someone wanted to create a psychiatric advance directive, they could be matched up with a facilitator. The organization provided private rooms for people to meet in, computers in case people wanted to type up their forms, and then had a notary on site. And because it was a group process, there were people who could witness for each other. Now you might be wondering, some of you might know about WRAP plans, the Wellness Recovery Action Planning process, and that is something that is been disseminated very broadly. It should be something that is complementary to psychiatric advance directives. And if any of you are trained WRAP facilitators, you will know that the WRAP plan has a crisis plan as part of it. The crisis plan really does look a lot like a psychiatric advance directive. It just doesn't have the legal attestation that makes it a legally binding document. So I would hope that we could sort of see the two things as being very much complementary to each other. And I've had with some of the peer support specialists who have gone through our facilitator training, those who are trained as WRAP facilitators have also said that they see the WRAP process as being a really good sort of preparation for developing a psychiatric advance directive. So my hope is that those things can be kind of complementary processes. So the other thing that we've done is just a little, a kind of small practical tool, but the idea then is that at the end of creating a psychiatric advance directive, you have a multi-page paper document. So we tell people, okay, it's been notarized, so it's got that, it's a legal document after it's been witnessed and notarized. Then we tell the person to keep the original in a safe place and to make copies of it, to give copies of it to people who are in their social network, their support network, their support team, not everybody in their social network, but the key people that they would want to support them in a crisis, to certainly make sure that their healthcare agent has a copy of the document, and then to disseminate it to any treatment facility to get it filed in the medical records of places where they might get treatment. But as a sort of practical tool to go along with that sort of multiple page document that people have, we developed just a wallet card. And the wallet card, that little on the upper right, this is something that folds up into thirds. So that's the front and back. So it's sort of got 6 panels of information, but the front, it folds up into a wallet card size, and the front card is that sort of saying, I have a psychiatric advance directive. But it's something that people can fold up and put in their wallet and have just some summary information for what happens. That's not the legal document, but we thought that might be a good tool for people to have something that they could carry around with them. And we made that, you know, it's a PDF that's available for people to print and make their own copies of on our Crisis Navigation Project website. So those are just a couple of practical tools. The other thing that we've done as we've sort of expanded our work, we've trained a bunch of people in how to facilitate psychiatric advance directives, but in this past January, we did a train the trainer. So this is our group of people who have been trained in our methods of psychiatric advance directive facilitation. I'm particularly pleased that in this group of individuals in Charlotte, North Carolina, it's a very diverse group, and it includes people with lived experience of mental illness. It includes family members and NAMI members, and it includes clinicians. You can also see in the back there's one man. The group is mostly women, but we do have one man in the back. So this is a group that's, it warms my heart to see them, because it makes me realize that I'm not the only one trying to work on this initiative, but we're doing the train the trainer model, where more people will be able to do what I've been doing with the training. And you can see they're all happy too when they got to the end of the training. So we kind of realized in Charlotte that there's a long way to go before these are something that are just used standardly in practice. They really do go along quite well with the principles of shared decision making. So it's something that we might aspire to, that this is something that people who live with mental illness will be offered, and that if they create them, that when they are in crisis and can't, for whatever reason, can't speak for themselves, that there will be something that will make clear what their choices and preferences are, and that those will be well respected by the people who are providing treatment to them. That might be kind of aspirational, but that's kind of where my mind is on this initiative that we're working on. We're getting here too. That puts me to the end of my slides for today. I have been paying a little bit of attention there to the questions, so I do know there's some questions there on the side. So we do have time for questions.
Great. Thank you so much, Phoebe. That was so wonderful. I learned a lot, and I know that a lot of people on the line learned a lot. So one question is, what if a person who wants a PAD has an IDD?
Yes. So I believe that you could use this document in the same, this would be relevant for a person with IDD. There may be some questions about whether the person kind of has if the person has legal decision-making capacity and doesn't have a guardian, then they can go ahead and if they're making their own decisions about their care, then they could develop a psychiatric advance directive or have a healthcare power of attorney that clearly stated who they would want to be in their care. But it would sort of, that person would have to be their own guardian for it to have the legal, the legal status.
Okay.
I think there are, I've noticed sort of in the IDD world in North Carolina that there's sort of multiple things going on around supported decision-making and sort of shared decision-making and supported decision-making, and kind of working on alternatives to guardianship in the IDD world. That's a little outside of what my scope has been, but I know that there are people who are working in that area.
Thank you. So we have somebody who's at applause for including peer support in the training.
Thank you.
So has PAD been used for substance use disorders? The question says, in Rhode Island, we are interested in comprehensive behavioral health advance directives.
Yeah. We've done some training with a substance use disorder recovery organization. And I think that the same kinds of principles would apply to people with substance use disorders. I don't know that Dr. Swartz and his group have mostly focused on people with serious and severe mental illness. But as we all know, there's often quite a bit of overlap in those things. But I think that the legal principles would also apply for people with substance use disorders.
Great. So we have a couple of comments. Thank you for the New York Times article, and we agree that the RAP process and the PAD development complement each other well. Oops. Sorry, that my question that I was just going to do just disappeared. Have PADs been used with people who are homeless?
Yes. And I think that there's, being homeless does not sort of preclude getting a PAD. And some of the people, the workshops that we've offered at Promise Resource Network in Charlotte, that's an agency that serves people experiencing homelessness and people with criminal justice involvement, and a lot of the people with very high vulnerability who might be frequently intersecting with emergency room use and that sort of thing. So yes, they can certainly develop that.
Great. So how have you seen PADs make a difference for folks in terms of being arrested or other interaction with criminal justice and police?
Yeah, I haven't really seen anything that's specific around criminal justice. I think it has been, the hope is that, and that's not been an area that I'm aware that people have researched. I think the idea would be if we had law enforcement who were well trained in crisis response, like officers who had gone through crisis intervention training, but if they were also aware of the existence of psychiatric advance directives, they might kind of know the right questions to ask of a person. So they might be better able to intervene in sort of mental health crisis. But I don't know that there's been work done around criminal justice system. We have had some people from the prison kind of ask, there were mental health professionals from a prison in North Carolina who were asking us about, what could they do to support the use of these. The problem, the barrier that we were running into with that is sort of how would you do the witnessing around, and what kind of choice did people actually have if they were in prison and getting mental health treatment. So that was a tricky area, but it's an important one when we're thinking about human rights, human and civil rights more broadly.
In many cases, the patient is first taken to an emergency department. I have not heard you mention that care site during this presentation. What kind of outreach have you made in North Carolina to the emergency medicine community or on PAD use in that setting?
Yes. So we have, I've certainly talked with psychiatrists who work in emergency rooms, and we have done quite a bit of work building partnership with one of the large health systems in Charlotte, Atrium Health. It's been a little bit slow going, I think, in terms of we've kind of realized that when somebody goes to the emergency room, they first sort of see a triage person, and there are kind of multiple levels of health professionals that would need to have some knowledge of psychiatric advance directives, but that really is the place where I guess they're most essential. And there's certainly, because what we would hope is that a person came into the emergency room, that they could quickly realize that the person had a psychiatric advance directive, that would be a useful tool for having information about the person and kind of about preferences for treatment and for who to call to support the person who's in crisis. That's still sort of in our aspirational phase, showing up in the emergency room. But we think it's also going to help the people who are the emergency responders in those situations. At our hospital, we've got some partnership going with the North Carolina Healthcare Association, which was formerly the Hospital Association. They are one of the organizations that was very much behind revisions to the involuntary commitment laws. So they're very much on board with promoting the use of psychiatric advance directives.
Great. You spoke earlier about people who are homeless. Is there anything specific that for homeless veterans?
Yeah, there's nothing specific going on now that I know of with homeless veterans. I will say that the VA, we worked a little bit with the VA in Durham, North Carolina, and they were offering facilitation of psychiatric advance directives to people who were involved in their psychosocial rehab programs. So they were actually offering that to many of the people that they served. And I would hope that overlaps with some of their services to homeless veterans as well.
This is a little bit longer. In the case of Ms. Jones that you presented earlier, she was at risk for a significant hypothermia or frostbite and possibly death before being brought to the crisis facility. Why was she in crisis? Since the PAD was used in this case to create a voluntary hospital admission, what would happen if Ms. Jones decided to leave the hospital and her voluntary admission?
Yes. So that's one of those hard questions. Yeah. Yeah. So I don't get around sort of, that was kind of like this ideal scenario where somebody who was like, yes, I'm going to be assent to coming in and going to be cooperative and all of that. I think if somebody was kind of found to be in need of hospitalization and kind of be in the kind of state that she was in, the person that I had in mind in creating that sort of ideal scenario was somebody who would have been experiencing psychosis and catatonia as part of that psychosis, and who was kind of had disorganized behavior and how she was, outside in the cold weather without being properly dressed. So the idea then is that, so if she had sort of said, I'm not staying, and if the physician evaluating her had decided that she, or even a master's level clinician who could do a commitment exam, if they were examining her and she was going to leave, and they thought that she needed to be in the hospital, then they might have to move forward with taking out involuntary commitment papers on her. So that would be sort of a clinical decision, based on whether the person met commitment criteria. But it also, in that scenario, it did give the treatment providers the option of not using those legal, kind of coercive legal interventions if she was able to kind of agree, yes, I'll come along with this, even if I can't sign myself in, if that makes sense.
Mm-hmm.
Yeah.
Okay. Could PAD be included in a medical alert type bracelet?
I think it could be. And that was something that we talked about sort of in our, trying to think about practical strategies. We thought about some kind of bracelet, and we thought about having people carry a flash drive. One of the places that I did a PAD training, though they were saying, well, sometimes our people don't even carry wallets or don't have a purse with them, don't have much information with them. So I think it's kind of figuring out, okay, well, what practical strategy is going to work for the people that I'm engaged with.
Is there any limit on the number of pages that a PAD can be?
There's not a limit on the number of pages, but we encourage people to not make them too long. And that is because in the busy kind of emergency room setting, short and succinct is going to be paid attention to more than a multi-page, very long document. So we encourage people to keep things very succinct and to be very clear about, this is something that is focused on medical treatment in a psychiatric emergency, so that they give very clear reasons for why they don't want a certain treatment. But sort of briefer is better just because that's going to be more likely to be paid attention to. Also, legible is better. When I have facilitated PADs with people, I generally type them on the computer as I interview the person and type their responses up on my computer so that when they can have a printed copy that's typed when we finish the process. The other piece that I didn't say, that people can also add like practical information into their PAD. So say somebody needs somebody to take care of their children if they are not able to, or to take care of their pets, or to take care of paying the rent. They can write those instructions, like these are the things that I need someone to tend to if I cannot do that. So that can be kind of added as an addendum. But again, fairly succinct and not too long.
How do you start a conversation with a family member, or if you're a person with mental illness, how would you start that conversation with the person you want to appoint as your person?
So to have the conversation with the healthcare agent, somebody that you wanted to have as a healthcare agent, is that the question?
Yes.
Yeah. So I think it would, when I've done facilitations, I've said, who are the people in your life that, when I'm talking to the person who's developing it, I say, who are the people in your life that you would want to be involved in your care? And then the person might think through, well, definitely my sister. And then I would say, well, is your sister going to be available? Does she know about, how to navigate the healthcare system? And then I would encourage the person to have that conversation, just say, would you be willing to serve in this role? And to make sure that the person understands what the role entails, because it entails kind of being available if the person's in crisis, and to be willing to represent the person's preferences, not their own. So that's the kind of, it's kind of having the conversation with the person and making sure they're willing to be in that role before it's written into the document.
And can anybody, anybody serve that role, or is it just family members?
Not anybody could serve in that role. It doesn't have to be family members. And in hospitals, they generally have kind of there's a way that they have a hierarchy of next of kin to contact in case of emergency. And I don't know that off the top of my head, but it might be spouse, and then adult child. I don't know the exact hierarchy, but health systems will have a hierarchy of next of kin to contact in a true emergency when they definitely need to contact somebody about making decisions about a person's care. So if a person is like, I don't want my spouse or my mother or my adult child to make my decisions, I want this person to make my decisions. Or if they don't want like a whole bunch of family members kind of arguing about what might happen with someone's care, these documents can help sort of clarify, here's the person that I have given authority to make my decisions.
In dealing with outdoor homeless directly in the past, are pads built to deal with the elements?
No, it's important to remember these aren't going to solve every problem that we deal with. I think for a person who is outside and homeless, there remains a problem of just that person being able to access treatment and services that they find helpful. So a PAD could sort of say, I have these preferences about my medication treatment, but it's not really going to say much else about, it's not going to have power over kind of what happens for other things in the person's life, if that makes sense.
Mm-hmm. And I think this is going to be the last question, and it's a little specific. Are there any upcoming seminars in Western North Carolina, i.e. Asheville?
Are there any seminars in Western North Carolina? I've done, I've presented at conferences in Western North Carolina and Asheville. There was also one of our trainers, one of the people who went through our Train the Trainer is at NAMI South Mountain, which is, I think she lives in the Rutherfordton area, so that is near Asheville. But if anybody wants to reach out to me directly, particularly if you're in North Carolina, because I can answer some of those North Carolina questions in the other states, but you can all reach out to me. I can direct you to some people in Western North Carolina that might be good resources. And sometimes I get out that way too and do trainings.
And one last question. With the workshops, was there an opportunity for preparation where people might need to go back and confer with the potential health agent before completing the PAD? Like, is there a series of 2 workshops?
Yeah, so we haven't, so oftentimes it might take several sessions with a person to develop their PADs. We have had a lot of people who've been able to go through the workshop and complete the whole thing in that sort of afternoon session. But then there are other people where it's a more involved process, where it might take several sessions to get things completed and to get all the different parts done. And our training of facilitators, we train our facilitators to continue to support the person through the whole process so they get to the end of it and it's, all the questions have been answered, the blanks have been filled in, and they know how to get it notarized and filed in their medical records and that sort of thing. But also, that just varies with person to person.
Wonderful. Thank you. So that concludes this webinar. I'm going to hand it off to Kelly because she has a couple of announcements. Thank you so much, Bibi. We really appreciate you taking the time.
Okay. All right. Thank you all for listening in today.
Yes, thank you again, Bibi, for your presentation. I am now going to change the screen over to a short evaluation and ask our attendees to take the moment to fill this out for us. Again, thank you for joining us today, and if you would like a letter of attendance, please send an email to my email address, which is located at the top of the screen there. Thanks again, and enjoy the rest of your afternoon.